Welcome to The New Health. I'm your host, Jessica Preston. In The New Health, we speak with thought leaders and innovators in healthcare who are making changes in the world. Today, I have with us James Maskell. He's a health economist who has spent his life learning about healthcare and chronic disease, and now is working to build a sustainable healthcare model. He's written 2 books, Evolution of Medicine and The Community Cure. We're going to discuss that today as well. Welcome, James.
Great to be here with you, Jessica. Thanks for having me.
Happy that you're here with us.
Yeah.
So tell me a little bit about the evolution of medicine and how you ended up in this space and your background.
Yeah, so I actually was trained in health economics at university. I went to university and I grew up in England. I was born here in America. And in that training, I recognized that in my lifetime, not just some great time in the future, but I recognized when I was having kids or when my kids were growing up, that we would face a calamity in America and in the UK, where essentially the cost of chronic disease would be so giant that neither economy would be able to contain it or support it. And I just recognized that this was not some far off problem. This was going to happen in my lifetime, and that ultimately, I had grown up with a different model of healthcare that no one knew about, and I just started on a quest. I guess at that moment, I left the UK where I grew up. I quit my job as an investment banker, and I moved to America to really understand what are the drivers of chronic disease. How do people get chronic disease? Is chronic disease reversible? And then being on a journey since then to think, now that I know that it is reversible, how do you do it at some meaningful scale that could take a bite out of that problem?
Yeah, that's wonderful. So I know we had talked a little bit earlier about acute versus chronic disease.
Yeah. That was really the evolution of medicine. So the medical system that we have now, even though many people see it as problematic, it was a reasonable way of delivering care at the first part of the 20th century. And that's when the majority of disease that you would see was acute in nature. So infection, physical trauma, accidents, those were the things that were killing most people. And as a result, you have this whole health system that gets built. And some of the things that we just think about are the way things are just a reflection of what the diseases were at that time. As an example, why do you see the primary care doctor first? Why do you see the doctor first? The reason you see the doctor first is that when someone comes in and there's an acute issue, time is of the essence, and you need a doctor who's going to identify what's going on in this patient as quickly as possible and come up with a solution as quickly as possible because of the acute nature of the problem, right? And so many other things come as a result of that. All of the insurance billing, the coding, the referrals to specialists, even physician specialization, all of that comes downstream from the fact of those are the kinds of diseases that we see. Then in the 1950s and really through until now, you see the growth of chronic disease, mainly lifestyle-driven chronic disease. And because the way that these diseases come about, the etiology of the disease, why people get them, how they come about, how long they take to happen is completely different. You end up in a situation where the medicine is not fit for purpose, right? And so the idea of the evolution of medicine is that the medical system needs to adapt to the new environment. And the new environment is chronic disease. And so I would say if you take a step back, what I've been doing for the last 20 years is understanding chronic disease, how it comes from, where it comes from, and then started to think, if you were just to start again and you were able to really think about how to do chronic disease, how would you do it? And then once you understand that, then start to think, okay, how can the medical system best adapt to this new environment? And in the Evolution of Medicine in the book, it was really written for the physician. I wrote the book so that I could hand it to a physician and say, read this, and if at the end of the 3 hours that it took them to read it, they would want to be part of a revolution. That the tagline was, join the movement to solve chronic disease and fall back in love with medicine. And I think we've helped thousands of doctors across the country go on that journey, and that's the sort of beginning of this evolution.
That's wonderful, and I've read the book, and that's how I first learned about you, and I joined the movement. Now I believe this is where the 4 Ps for medicine would come into play?
Yeah, the P4 medicine is an interesting concept, and it's a good way for people to grasp what I'm talking about. This is actually popularized in Silicon Valley in some ways. They were talking about, what does this new medicine look like? What does this new health look like? And ultimately they called it P4 medicine. And P4 medicine, I'll just go through the 4 Ps. The first and most important P is participatory, right? All the other Ps are less important than the first one, which I think is participatory, which means that in the new medicine, people need to actually participate in their care. Again, in the old days, if you get an infection, you don't really need to participate. You just need to take the antibiotic, right? That's all your participation. But if you have a lifestyle-driven chronic illness, a fundamental truth is that you're going to have to participate to reverse it. So that's the first P. The next P is predictive, right? You can actually predict future disease. There are ways that you can predict future disease, and ultimately a lot of the work and the doctors that I work with is about understanding that before you get not just diabetes but Alzheimer's and stroke and autoimmune disease, before you are in that category of having the disease, you can predict that you are going in that direction, and you can stop and go back in the other direction, right? So there's predictive. Preventive, right, so that you're actually preventing future disease by taking action now. That's the third P. And then the fourth P is personalized. And so much of medicine is not personalized. So much of medicine is medicine for the average, and this is medicine for the individual. So P4 medicine is the sort of ideal of what we're going for. I called my show the Functional Forum, and I went into functional medicine because I believe that functional medicine is the best way today to actually practice P4 medicine. P4 medicine is a concept. Functional medicine is an actual operating system that doctors can actually learn and actually deliver today, and that's why it's been a central part of my platform.
That's wonderful. So you are our first guest on our first episode, so I would love if you would give us a definition for functional medicine for us.
I mean, the easiest way to think about it is, medicine, as I described, the old medicine is medicine by symptoms. You have this symptom, the doctor works out what the disease is, and then gives you the drug. I mean, that's basically the way that it was. Functional medicine is medicine by function. Over time, you don't just suddenly get a chronic disease. The body is functioning normally, and then suddenly the function starts to dissipate in one or more areas, one or more systems, and over time, if it gets worse and worse and worse and worse, then eventually you have a symptom, and the way back is not to treat that symptom, the way back is to rebuild the function. It's as simple as I can say it.
Okay, and we do that through, and I know you mentioned lifestyle before and chronic disease, and I think that has been lost over time. The connection between chronic disease, as you said, it develops over time slowly, so we can't reverse it in a day. We didn't build it in a day. And that is very much based on how we live our lives.
Yeah. Lifestyle is the foundation always. So lifestyle, how we sleep, how we eat, how we take care of each other, how we love, how we take care of our stress, all of these, how we nurture in our environment, how we create a healthy environment in our home, in our workplace, all of that is the foundation. And, lifestyle is critical. However, what functional medicine, the sophistication of the functional medicine model, is that there are ways to tell what function has gone down in which organs and systems, and then rebuild specifically. And that's one of the unique things about this new paradigm, is that you can have 10 people with type 2 diabetes, and you can actually go back in their history and you can look at their function. You can see 6 of these people got type 2 diabetes because mainly food. 2 of them got it from mainly toxins in the environment that mess with the insulin sensitivity, and 2 of them got it from excess stress. And it's always combinations of those different things. But if you look at it if you look at it from a personalized understanding and you see why people got there, then you can work out how to reverse it. And that is the work that doctors are doing in communities all around the country right now. And part of the sort of the end result of the evolution of medicine and many others' efforts is that in every little town across the country right now, there is a functional medicine doctor that is in the business of restoring function.
And you're a part of that mission, and I'm so excited about that. I'm so happy that you brought that forward for us. So tell us a little bit about Community Cure.
Yeah, so the Community Cure was just really the next step in that journey, which was that I recognized that in functional medicine, we like to communicate that this is the root cause, right? That we like to deal with the root cause, the root function issue that I mentioned earlier. A lot of times, the root cause is a lack of community, right? Is social isolation and loneliness. Loneliness, people who are lonely have a between 20 to 40% higher risk of the biggest killers. Alzheimer's, heart disease, stroke, diabetes, loneliness plays a key role in there. And not only is the loneliness bad for you, but actually the structures that most people need to do new healthy behaviors is also community. And the community cure was really written as a way to think about the way that I could see that medicine could actually, it's a different question. So in the evolution of medicine, it's like, is chronic disease reversible and how can it be reversed? And right now we see that you can go to a doctor trained in functional medicine and they will help you reverse your chronic disease. But as an economist, there is something wrong with that equation, which is that that can't work for 330 million Americans. That can work for maybe the top 10, 20, 30% of society that can afford to go to a doctor, that can afford to practice in that way. What are we going to do for everyone else? And what I came to understanding, and the reason I wrote The Community Cure, is that there was an emerging way of practicing this functional medicine where people were actually treated in groups, in cohorts. And through those cohorts, people were doing these healthy lifestyle behaviors, were improving their function, but were actually creating new friendships around people who also wanted to get healthy. And that, I believe, is the foundation for a truly scalable, truly inclusive new healthcare system.
Thank you so much for that, James. Well, how can people reach you, get in contact with you, learn about what you're working on right now?
So on my website, jamesmaskell.com, you can see the different projects that I'm working on, that I'm involved in. And, I have been, involved, I am currently involved in a number of projects all around the same mission. And then I'm most active on Instagram, Mr. James Maskell, and you can find me there and see what I'm doing day to day. And love to connect.
Oh, that's wonderful. Thank you so much. So thank you so much for joining us. James will be back with us next week to speak with us more about his work and how he is revolutionizing healthcare at this time. And come back after these messages and for our next guest. Welcome back to The New Health, and I'd like to introduce you today to Adam Lane Smith, the attachment specialist. So Adam, you are here to speak with us about attachment styles, and please tell us a little bit about what that has to do with health and wellness.
Yeah, so really quick, attachment is the way that we form trusting, fulfilling, and transparent relationships with other human beings, and the way we learn who to trust, because you have to discern that. And we learn this in childhood. We learn it the moment we're born, over the first 6 months, over the first 6, even 12 years. And we develop into attachment styles. If we develop secure attachment, we learn that people will work with us, that transparency is good, that we can trust people, and we learn a good filtering process for exactly who to trust and who not to trust. But for most people, actually most people nowadays, 65% of people, that's not the case. We learn that we cannot trust other people. We learn that we have to be closed off. We learn that we have to be a little bit secretive, not sneaky or manipulative, but secretive. And we have to please other people in a variety of ways. And there's a couple of ways that that can get broken, and it's impacting our world in a tremendous way right now. But for health, it destroys your long-term health. It destroys your daily health, your long-term chronic health. Everything gets destroyed if you have broken attachment.
So tell me a little bit about the neurochemistry. We've talked a little bit about the hormones or how that's related to this health component.
Mm-hmm. So the most common attachment problem that we see is called avoidant attachment style. And people with this style would never diagnose themselves with it because it's not even a diagnosis, it's a descriptor of survival. These are survival adaptations for broken environments. If nobody is going to work with you, and if your brain learns early on that other people are arbitrary, that they are untrustworthy, that nobody's going to help you, nobody's coming to save me is a thing that avoidant people say quite often. If you learn that other people, when they get stressed out, that they are completely untrustworthy, so you have to play your cards close to the vest and make sure that nobody gets the best of you, you can develop what's called avoidant attachment style. An avoidant attachment style is designed to keep you strong and programmed properly in an environment without support. So you can be incredibly successful in finances and business, in any areas where high achievers are found typically, but your brain chemistry is very off. It turns off through the high levels of cortisol that you get, the stress hormone. As you know, with that high level of cortisol, it blocks your receptors for oxytocin, which is the love hormone. It makes you feel safe and bonded and connected to people. But it also shuts down any events where you would get serotonin. So people with high levels of performance usually have very low serotonin, the long-term satisfaction neurotransmitter that makes you feel content, warm, and fulfilled in yourself at all. So you shut down all of those pieces, feeling good and connected to other people, ability to bond, feeling content in your life, and you also block out most of your receptors for being able to bond with other people by solving stress, vasopressin bonding. So you're just flooded with cortisol. And the only thing that's left to you to bring your nervous system down is dopamine. So you have to use strategic dopamine drops throughout your life, throughout your day even, to try to bring your nervous system down and give yourself any kind of pleasure.
So when you were talking about from a young childhood age with the for the avoidance attachment, so avoidant. And so there were 3 attachment
There are
styles.
3. We can go into them if you wish.
So, okay, just name the 3 for me.
Absolutely. So there's avoidant, the primary one that most people experience. There is anxious, which is approval seeking, that says, I am the problem. Other people are not. I am inferior somehow, and people can see it. So I need to cover up. I need to please other people so they don't abandon me. It's fear of abandonment, and it's fear of powerlessness, that I am only having power and control in my life and safety when other people approve of me and take care of me. And there is a blend of the two. Everyone always asks. There is a blend of the two that we would call disorganized style, meaning it cannot be organized in either category. It's both.
Okay, and you said the most common is the avoidance attachment style. So what you were speaking about for dopamine and cortisol, so from a young age, certain receptors aren't used in this?
Absolutely. So the young child is high level cortisol all the time. And what this looks like is high performance. It looks like they can achieve, they can think really fast, they're often high intelligence. It just optimizes you for raw survival. And it takes you to a heightened place where you are always on, always aware, always focusing, always sensitive, always tracking what other people are doing, because that keeps you safe. Their mood changes are your unsafety. You have to be aware of other people's mood changes to see if they're going to betray you or screw something up for you. So they do this from young childhood, but the only way to manage it is with dopamine. Short-term, temporary little boost of feeling good. It could be candy. It could be as you grow up. It could be more adult materials. It can be a variety of chemicals, a variety of activities. In romantic relationships, as they date, it's finding a new partner every 6 months as the novelty dopamine wears off. It's just an endless flood of dopamine because they have nothing else to bring themselves down at the end of the day.
Okay, so when they have this high cortisol and then dopamine to kind of counteract.
That's it.
That they can't, and so what happens long term?
So long term, your benefits in the early stages of life are fantastic. You'll focus better than other people do. You'll stay away from drama. You probably will grind all the way up to the C-suite executive positions real fast. Or you'll start a company because you don't trust other people to have control of your life. Or you can manage your team really effectively because you don't get sentimentally connected to them as much, which is great. And your finances are great. You can control them. Money, they're not avoidant people are not greedy, but they see money as safety because they can turn it into any other resource, and it's the only thing they trust because they can't trust people, so they trust money. So they are very good with money, usually, and they control the nest of it, and it's great for them in the first half of life. Now what happens is either they don't find a partner because they refuse to trust anybody, or they do find a partner and the relationship dies over time because they don't feel bonded and proper connected. The other person doesn't either. And if they happen to connect with an anxious partner and they have babies together, they don't bond properly with their children because you're in a survival state. So you don't bond with your kids, you don't bond with your spouse. Your kids and your spouse may turn against you. You probably lose a lot of things later in life. This is why we see a lot of midlife crises, but also that 15, 20-year divorce, alienation of children, very few friends. And then the later half of life, all the piper comes for his due, right? The piper comes for his due, and you see that your immune system is trashed. You see that the constant stress has destroyed your body, a massive level of heart problems in the 50s and 60s, a just complete shutdown of your body system. So you spend all of the money that you've spent the first half of life building, you just blow all of that money into the medical system in the second half to just keep yourself barely functioning as your family leaves you, as you lose everything that you have built. I've seen this again and again and again. It is so heartbreaking.
I think it's important for us to also say that this is, for people who are watching, this isn't a death sentence. This doesn't have to be. And there are ways that people can work with this for helping themselves with learning about these attachment styles?
This is the number one message I want to spread, because I've spent years talking about attachment, and it's fortunately has brought it into mainstream. And I've noticed a lot of mainstream articles in the last 6 months, in the last year, all of a sudden talking about attachment now that I've gone viral everywhere. But the thing that they all get wrong, the thing that everybody gets wrong, so terribly wrong, and I hate it, is they think that your attachment style is your astrology sign. This is just what I am, and I will never ever change, and I'm doomed, or other people have to accommodate me, and this is just what I am now, and that's not the case. The goal is to correct this problem with avoidant clients who come in, for example. I work with them to build 2 or 3 trusting relationships. That involves learning your patterns for how to trust people. It's called the 4 levels of trust. When you learn and you can discern exactly which people to trust, only 2 or 3, that brings your cortisol level down. And when you manage your nervous system properly, I know you help a lot of people do this, when you manage your nervous system properly, that cortisol dissolves and goes away, and then what happens is your oxytocin receptors suddenly open up, and you can properly bond with those people that you know you can trust. You can bond with them hormonally. And it's a rush of experience that people have never felt. They've never felt their joy and that pleasure in life. Avoidant people only get about 20% of the pleasure of life, and they're leaving 80% on the table. When you get the oxytocin rush, you open up and connect, you get the serotonin rush. This is where you get that contentment, that bonding feeling. You belong to a tribe and you are cared for. You only need 2 or 3 secure relationships to change your life. And as you know, that improves your immune system, it improves your mental functioning, your fertility, everything across the board.
So you mentioned 4 levels of trust.
4 levels of trust.
Would you tell us what those
Absolutely.
4 levels?
I have no
love
problem with that. So I've just lied to you. There's 5 levels of trust.
5
So
levels of
avoidant people
trust?
out there are like, I knew he was lying to me. Level 1 is there's level 0. And everybody starts at level 0. We don't give trust away for no reason. Trust has to be proven. Why do you trust somebody? You can hope that someone will work out and allow them at level 0 and allow them to begin to test for level 1, but every person begins at level 0, or they go back to level 0. Level 1 is, are you consistent and self-policing with an explicit code of conduct that other people can track? So do you correct yourself back to it when you make a mistake, or do other people have to make you and force you to be good? If the avoidant person has to force you to be good, they will never trust you. If you're self-policing and consistent, especially during stress, and you say, okay, I want to lie, but I am an honest person. I cannot lie. I have to tell you the absolute truth, even if it kills me. So here we go. Let's get through it together. That will amp up their trust and respect for you slowly. And if you can begin to do that more and more, when you get it wrong, you self-correct. That's level 1. This is base acquaintance. They will remember your name and allow you in their home occasionally. It's not friendship yet, but that's level 1. Level 2 is like it. It is, are you consistent and self-policing with long-term goals? Do you have long-term goals that you can tell this avoidant person? And can they track that? And do you always aim for it? Even during stress, you don't abandon it and say, okay, I want to build a loving family, but I'm going to go smoke crack in my garage. No, it's, I am going to build a successful, healthy family and manage my stress appropriately. When you get it wrong, do you self-correct back so they don't have to? This is level 2. This is a basic friendship, or maybe beginning to date, right?
So I'm going to stop you here.
Go ahead.
Because we are about out of time.
I hear you.
So we are on level 2, and I think next week we should start off with our level 3 and 4.
That sounds fantastic.
And can you please share with our audience how they can find you and connect with you about what you're working on right now?
Absolutely. So I'm Adam Lane Smith, the attachment specialist. My website is adamlanesmith.com. You can find my book, you can find my courses, my coaching, and my new retreat that's coming toward next year.
That's wonderful. Thank you so much. Any call to action, any last little bit that somebody could do right at this moment?
Absolutely. Sit down and write out a list of all the people in your life right now and give them a score, 0, 1, or 2. You'll probably be surprised about the numbers of people in your life.
What is the score for?
Trust.
Oh, 0 is the least amount of trust? 2 is
0 is I don't know.
0 is I don't know. 1 is?
What we just talked about.
Okay. Oh, on the scale of 1, 2.
Scale of 1,
and
2,
stay tuned
0,
for
1,
next
and 2.
week when we get to the next
Correct.
levels. Right. Thank you so much. Welcome back to The New Health. Today I want to introduce you to Dr. Heather Gessling. She is a family practice physician in Missouri, history of being chief of staff at a hospital in Missouri, has been in practice for about 14 years. Welcome to the show, Dr. Gessling.
Hi, glad to be here.
So happy you're here. So Dr. Gessling is a family physician working in an area called direct primary care, or DPC. Could you tell our audience a little bit about direct primary care?
I would love to. Direct primary care is an amazing way for patients to receive the care that they deserve. And it's also an amazing way for physicians to get the love of medicine back in their life. They are not controlled by insurance companies or accountable care organizations. They get to practice the way they thought they would always be able to practice when they started medical school, with autonomy and independence. It's a membership-based model. It's not exactly the same as concierge or boutique. It's concierge or boutique is more of a um, uh, in increased cost per year versus direct primary care. Direct primary care is typically just a low monthly membership, anywhere from $50 to $100. It limits the size of the panel of the physician, and the physician is able to give more one-on-one, direct, quick care, because the panel size typically is lower than when they're in the insurance model. The patients can typically get a same-day visit or a phone call from the physician or a telehealth call. Their questions are answered quickly. And another thing that is sort of a misconception in DPC is that if you enter into this type of practice, you won't be able to use your insurance if you have it, which is not true. Patients who have insurance can still use them for labs, although a lot of times I can get their labs cheaper than what they would pay for the copay if they submit their labs through insurance. They can use their insurance for imaging, or if they have to go to the hospital or see a specialist. It's just my service that is a cash pay sort of situation, just a monthly membership.
Wow, that's wonderful. That sounds not only liberating for the physician, but also for the patient to be able to have that access. And when you say panel, you mean number of patients that you are
That's
allowing
right.
into your practice. So when
Yeah.
you say that DPC, direct primary care, has a smaller panel of patients, what is the number? What is a comparison between an insurance-based physician? How many patients would they see versus how many you see?
In my current practice, I'm probably seeing a quarter to a third of what my panel was when I was in the insurance system. I had several thousand, and I currently have my panel at less than 1,000, and I feel very happy and comfortable with that. I feel like I can manage the patients quickly, and also it's not becoming to a point where they're not getting the care that they have signed up for. I am able to see almost any patient same day at this point.
That's incredible. So I know that the wait right now in the healthcare system for insurance-based can be weeks to months, even if there's something that is urgent or emergent. They just can't get in with their doctor. So
Yeah,
you're
and
able to
yeah,
get them in.
a lot of that burden happens because physicians only get paid if the patient is seen in person, which adds an incredible load to the healthcare system. The physician doesn't get compensated for their work. I mean, there are some codes that can be used if a phone call is made, but physicians don't get compensated for their work if they manage the patient outside of the system where they're seen in person. That's not the way it is in direct primary care. The physician is getting compensated regardless of whether that patient shows up in person. And if the patient needs to be in person, I bring them in. If I can manage them through a phone call or a telehealth, that's what we do. And it is a much more efficient way of being able to take care of their needs.
I really love the direct primary care model. I'm so happy that we're talking about this today. So if any of our audience has questions, I want to bring a few thoughts to mind that I'd love to discuss for clarity's sake. So when it comes to, you have a panel, it's a smaller number of patients. So you said under 1,000, where before, let's say if you're seeing about 900 now, you were seeing about 4,000 per year. So is that it?
Yeah, my
And
panel was very large when I was in the insurance-based system. I actually had two different clinics, and both of them had a panel of 1,500 to 3,000. And so, and I was doing it. I was managing, and I think the patients were being taken care of well, because I would never do anything less than, take care of their needs properly. However, it was a very stressful system for both me and the patient. They weren't getting as much time as they deserved. I wasn't able to give as much time as they deserved. I was required to do an incredible amount of computer work at night to document, to satisfy insurance requirements, not just because of, the fact that those things need a document for their care, but mostly to satisfy insurance requirements or requirements for the accountable care organization we were in, that mammoth organization that sort of demanded things of the physician, whether or not they were good for the patient or not. So within this system, there's an incredible amount of freedom, and just the freedom itself to be able to talk to patients is healing. Patients love it. They love being able to know that they're cared for and be able to have deep conversation that can dive in and get to the root of different diseases, and not just, oh, I only have 2 minutes, and so here's your antidepressant, which is what happens all the time in mainstream medicine. And it's been a problem for a long time.
So I love that we're talking about time that is spent with a patient. So what do you say you are spending the amount of time with each patient is compared to when you were in the medical model with insurance?
Oh my gosh, it's so much different. Every patient slot I typically do 30 minutes. Sometimes it's 20. If it is a strep throat or a urinary tract infection, maybe it's a quicker visit. But in general, I would say 5 to 6 times length of a visit than when I was in the insurance model.
Well, my guess is your patients also, when they present, know that they're going to get that quality time with you. So they may even present with a little more relief, as opposed to the anxiety we can see when we are presenting as a patient, where we know we have a very limited amount of time of our provider that's in front of us. We know what one question do we have that we can get answered in these 5 minutes. So they must present with more relief with, okay, Dr. Gessling's going to listen to my needs and she's going to really meet them.
Oh yeah, isn't that the truth? And that in and of itself builds trust. And we, with every visit, there's always things that we end up uncovering or bringing to the surface that I know would not have been discussed in a quick visit in my previous practice. And so I love that we get to dive deep and really do deep healing, really do foundational work at most visits.
I love that. And also, I think we want to also make clear that with direct primary care, you can still see everything. You're still a family physician. You're still addressing all of the needs of a patient that's going to their family physician. You still cover all of those bases.
Yeah, that is sort of a misconception among patients that, oh, I'm not really a regular doctor anymore. But I tell them, I'm like, no, I'm just the same doctor that I've always been. I'm family medicine trained. I take care of all needs. I take care of all ages. You can use your insurance for anything else that you want. And, they feel surprised because they think if they're not in that insurance mainstream healthcare model, then somehow they're venturing into alternative medicine, but that's not true.
Yes, I think I think it would be maybe a good way to explain this is you're the exact same doctor with a different behind-the-scenes business model. So if a patient didn't even know, they would just come in with still the same exact concerns. You just have a different business model that works really well for you as a physician to have more time, more quality visits for your patients, more bandwidth to be able to provide more care, more curiosity, more research even on your end for what those patients may need.
Oh, I love that. That gave me chills. That's exactly right. I mean, it's the business model of mainstream medicine is broken. It does not lead to healing. It only leads to propagation of that business model. They don't necessarily want you well and healthy and healed because that would not be beneficial to their financial system.
Yeah, so it looks like the DPC model for providers even, it's encouraging medical providers, physicians as yourself, to encourage more healing. encourage more time with that healing mode and modality.
Yeah. Yeah, that's correct.
No, that's terrific. And you do still, and I know you said people think it may be some alternatives, and I know we'll talk about this more in the future, but you do work a little bit in that alternative space as well.
Oh, yeah, absolutely. Over the last several years, I have learned that I wasn't taught how to heal when I was in medical school. I was really only taught how to diagnose and treat. And that hit me like a ton of bricks one day. And I realized that want to help people and help patients heal and reverse disease, not just throw a medicine at it that treats. I didn't have that concept before, but now I do. And I get to the root cause, and I want to figure out what's happening metabolically in their body to be able to reverse their diabetes, hypertension, or quote high cholesterol, which is a topic in and of itself, or reverse their gout, or heal their arthritis. I mean, every single condition your body can basically manage. You give it the right tools, and you reduce the toxic load and reduce the cellular stress load, and your body can take over and heal that.
That's amazing. So, Dr. Gessling, tell me a little bit about what you're working on and how people can reach you.
Yeah, well, if you're in the state of Missouri, my website is GesslingFamilyWellness.com. I have 2 locations in the central Missouri area, Macon and Boonville, and I'm on Twitter at @HGessling. I'm also doing a detox project with my wonderful friend, Christian Elliott, who's a wellness coach. And we have started a program called Detox U, and you can find that at www.healingunited.today. And I think you have to put that www in there because the system is not used to the website and not used to the .today. So it's www.healingunited.today. And you can sign up for our email newsletter. We're going to do our next free 2-day detox workshop in September.
Thank you so much for that. Well, thank you so much for coming and joining us this week. I'm looking forward to having you back next week. So everyone, if you'd like to return with us next week, hear more about Dr. Gessling's work. We have some really exciting topics coming up. And please come back after these messages to join us for our next guest. Welcome back to The New Health. We have with us Dr. Cheng Ron from the Texas Center for Lifestyle Medicine. Welcome, Dr. Ron.
Hey, thanks a lot. Thanks a lot for having me here.
So happy that you're here.
Yeah.
So Dr. Ron is the CEO for the Texas Center for Lifestyle Medicine, and I would love to hear a little bit about what you're working on and what your purpose and mission are right now.
God, I'm so glad you asked. Thank you very much. So, Texas Center for Lifestyle Medicine was founded in 2017 as a bit of a dream. And the dream was to see if we can offer the absolute best style of medicine that almost seems like it's concierge, but it's not, within medical insurance settings, Medicare, and stuff like that. So, fast forward to now it's 2024. Not only have we done that, but I do think we've surpassed in our outcomes and metrics in a lot of chronic disease states, and especially the more complex ones as well. And so it's really fun to see my team and how we engage with patients and also hear the patient stories and share the patient stories, which we do often on social media, so that we can sort of create this unity and this bond in medicine, which I do think is missing. But I'm super proud of my team.
Oh, that's so wonderful. I love hearing all of that. And you're insurance-based, actually.
Correct, yes.
That's really incredible in this whole world where things are changing a little bit into that lifestyle medicine space, where a lot of it is not insurance-based.
Actually, believe it or not, most of it is still insurance-based, but not many people can make it so that it stays for a long time. It's sort of the unfortunate situation. There is a business to medicine there. So I think the way that we all have to look at it as a community is that there's good medicine to be practiced, but then we have to redefine what medicine really is, the new medicine, if you will, right? And how it looks forward into the future. Because we're kind of in this world of there's internet, and then there is artificial intelligence, and we're in this world of hyper information right now, right?
Yeah.
And so what happens is that people are thirsty for information, but information can come from any source. So I do think the value of what we do should be educational and looking at the community, and that's what makes us super special.
Dr. Braun, how did you get in this in the first place? How did you come from, I know you went traditional MD training, and
Yeah.
how did you get on this path?
Yeah, well, I was still original MD's training.
Yeah.
I think that whenever you hear sort of my early life, you kind of understand where this all came from. So my mother is an acupuncturist, Eastern medicine, Chinese medicine doctor. And then my father's side of the family has also Eastern medicine, but my father is an MD PhD in research. He's the Dean of Pharmacoinformatics, University of Houston Pharmacy School. He's at Baylor College of Medicine. Has the most number of American Heart Association medals,
Wow.
et cetera, et cetera. So we sort of have this East meets West approach. But for me, it was all one thing to really begin with. So even going through medical school, like my job in medical school is to identify like what's wrong, what's wrong with the system. So I think from a systems point of view. And a lot of what I do is trying to engineer a system that actually works with the current systems so we can all immediately benefit. So that comes from this principle called inclusionary principle. We have to include everybody. So right now medicine is a bit disjointed. You have this type of medicine, you have lifestyle medicine, functional medicine, et cetera, et cetera. And then that can create sort of this air of conflict and exclude, and we don't necessarily want to do that because unity is what really brings us together. And so my dream is to not label the medicine eventually, not label the medicine. Good medicine really should be practiced, but including people in the conversation, also learning from our patients. Like my favorite thing really is like learning from our patients. And that's why we developed such a close-knit relationship with the Texas community.
That's really incredible. So this inclusionary, so when we talk about inclusionary, I know you and I've spoken a little bit. I would love to share with the audience, and I know you briefly spoke on it. How can we help people in that inclusionary space? It's medical providers, it's patients, it's both?
That's a tough one. So it's medical providers, it is patients, it's their family members, it's also the insurance companies, it's the hospital systems, it's the social workers, it's the psychiatrists, it's everything, right? And so right now, I think the problem originally started when we tried to categorize medicine and different diseases with these disease codes, if you will, ICD, International Classification Diseases. So what happens is that governments across the world were trying to get data for population health, meaning that they want to know who's sick, when, at what time, who's more likely to be hospitalized. But what happens then is that you start making programs for this population, and we kind of lose sight of the bigger picture of what's going on. You can have like a chemotherapy for cancer, or you can have high blood pressure medicines, and then you have diabetes medicines, et cetera, et cetera. But then you have different bodies, regulatory bodies overseeing these things. But when you put the whole big picture together, you realize there's a lot of commonalities that are in there that people aren't seeing, like sleep, like loneliness. That's probably the biggest risk factor for all diseases and mortality is loneliness and isolation, right? You see other risk factors as people feeling, especially during the pandemic, as if they're isolated and they're forced into sort of this isolation. And then that creates, relationship issues and stuff like that. Like this is the real root of issues with all across medicine. But these are the data points that we should be tracking. But it's not really until the last 5 years or so the government's really wanting to track this, called SDOH, social determinants of health, right? But that's where we're going in the very near future. I'm super excited about it because I do think that the way that medical policy is kind of going towards that so we can practice our style of medicine, whether it's lifestyle medicine, functional medicine, et cetera, et cetera.
Can you give me a description of lifestyle medicine?
Yeah, so lifestyle medicine to me means that we have to look at the way that we're living, okay? Lifestyle medicine is looking at not just our lifestyles, how it pertains to disease, but like as a human, as a whole population, right? Because if we just look at one human and what his or her lifestyle is about, we're missing the much bigger picture. Because part of lifestyle is connection. And part of connection is the way that we kind of interact with each other, right? So in our facility, we do a lot of groups, group interactions, group visits. We do it virtually, online, and we do it in person. And so because we do all that, we're seeing how people live their lives, but we can see it through other people's lenses as well, and we come together and talk about it. I mean, this is what the community's for, is communities talk about it. So I've always found it silly that you can go to any city in the United States and go to church or temple or synagogue, but you can't go to a doctor's office and talk about your health as a group and feel safe. That's the thing, right? The sense of safety and certainty has to be there within the medical profession. And I think it's time for medical professionals to open up their space to have meetings, if you will, right? And talk about health, not for doctors to educate patients only, but doctors to learn from the patients. And in every meeting, I tell the patients that I am here to learn from you. I don't know what your life is like. But if I do know, and another patient comes by, I can tell the patient, hey, you know what? You're not alone. There's other people that are just like you. And let's meet on Thursday, right? Because you're going to meet a lot of them. And that's how we've been able to develop our reputation in the community.
How are you getting patients interested in getting to a community or a group? Because we're so used to getting behind that closed door, having that private space. How are you getting them involved in a group?
This is actually a really easy question to answer, and although a lot of doctors have asked me this, I have a nonprofit, the Physician Transformation Institute, where we educate physicians on communications and strategies. And so I like to start off with the patients with two questions, right? Number one, like, what is the best 10 out of 10 outcome you want to achieve for your health today, right? Mm-hmm. And then number two is, what's my role in your health? And patients usually take a big pause, be like, no one's really asked me that before. Mm-hmm. But what I did is I put the control like in the patient's hands, and I'm the guide. I'm not the patient's hero. The patients are their own heroes. You're your own heroes. We're own heroes. We can't be anyone else's heroes. And what happens then, it creates this mindset, oh, I'm here for me. I'm not here for just a prescription or anything like that. I'm here for me. And I think when we open up conversations like that, it's really easy to ground someone's mentality in the sort of the safe space, because we speak like we're coaches, right? Mm-hmm. And I think that is a process called motivational interviewing, and there's other different names for it that I train my team on. So once a month, we shut down the whole practice with full day training, usually the last Friday of every month. So that's what we do. We look at case scenarios. We're looking at how we can eliminate conflict within each other, and what type of patients are looking for a communication style. We even program the artificial intelligence to let us know that. The AI is able to look at what the patients are saying and how they're saying it, and say, hey, you know what, there are these words you might want to avoid for this particular person because this person has either PTSD or something like that. Or it'll say that, hey, this is person's an engineer, you want to have very clearly listed outlines for them.
That's wonderful, and I'm sure we'll talk more about AI in the future.
Yep.
So thank you so much for coming today. I know we have a couple of other segments and topics we're going to talk about. Yeah. Could you please let our audience know how they can reach you and what you're working on right now?
Yeah, absolutely. So the website for my clinical practice is texascenterforlifestylemedicine.org. I'm pretty active on Instagram, so follow me on Instagram. Just search my name, Chainron MD. For those healthcare professionals, I do have a huge education and service for healthcare professionals to teach them the way that we actually run our practice and business. So find me on LinkedIn, once again, Chainron MD.
That's wonderful. Well, thank you so much again for joining us. And we are going to wrap up our episode of The New Health, but come back and see us next week when Dr. Ron will be joining us again.
This has been a Now Media Networks feature presentation. All rights reserved.